So good morning, everyone, and thank you, Hun, for the introduction, and to the organizers for inviting me to speak with you today. And so what I'm hoping to go through in a bit of a whirlwind fashion is what I really hope will truly become our next generation of therapies for myeloma. And so I've titled this The New ABCs of Myeloma Therapy, Novel Antibodies, BiTEs, and CARs. And these are my disclosures. So we've already seen several of these type of slides from David and Joe's talk, showing us the immune microenvironment in myeloma, and we know this is an immunosuppressive environment. And so what this slide is really designed to highlight are several of the approaches that are now being taken to overcome this immunosuppression. And so we heard from David about vaccine strategies and from Joe about daratumumab and elotuzumab. And what I'll be focusing on are cellular therapies, particularly CAR T cells, the bispecific antibodies or bispecific therapeutic engagers known as BiTEs. I'll touch briefly on the role of PD-1 or PD-L1 antibodies in myeloma. And then I'll finish with one additional novel antibody drug conjugates that are starting to show some promising activity in early studies. And so very briefly, a CAR or chimeric antigen receptor is really a very novel way to combine the recognition domain of an antibody with the signaling domain of a T cell. And so this uses a gene transfer technique to stably express this novel receptor in the T cells, which can then be passed on to the progeny of those cells and have long-lived persistence within the patient. And the real advance for this technology, which has been around now for a couple decades, was the addition of additional co-stimulatory domains, most commonly CD28 or 401BB, which allow additional proliferation and particularly survival and persistence of these cells long-term. And the greatest successes, of course, have been with CD19 targeted CAR T cells, particularly in B-cell malignancies, and we've just recently had the approval of the first two of these products by the FDA for treatment of relapsed refractory ALL or non-Hodgkin's lymphoma. And so the target that I want you to become familiar with for multiple myeloma, the one that's showing really the most promise, is called BCMA, or B-cell maturation antigen. And this is a receptor for two ligands called BAFF and APRIL, and together this receptor ligand complex is responsible for maintaining normal plasma cell homeostasis. And this is a good target because it's expressed primarily on plasma cells, a small subset of post-germinal center B cells, and a subset of dendritic cells, but really not expressed on any other normal tissues of the body. And it's highly expressed on multiple myeloma cells, almost universally in patients, although the intensity of that expression can vary from patient to patient. And finally, BCMA can actually be cleaved from the cell surface and circulates as a soluble form in the serum, and you can measure this in patients, and it actually has prognostic significance and can be a way of following response as well. Importantly, BCMA is not just sitting on the cell surface as a target, but actually promotes myeloma pathogenesis. So if you knock down BCMA, you can actually decrease the viability and increase apoptosis. If you overexpress BCMA in myeloma cell lines, you get enhanced growth. And this is some nice work from Ken Anderson's lab. So all of this together really provides very good rationale for BCMA as a target for immune therapy. So Korkendorfer and colleagues from the NCI were really the first to develop a CAR specifically for BCMA, and they explored this first in preclinical models, demonstrating significant activity both in vitro and in vivo. And then they conducted the first in-human clinical trial of autologous CAR T cells targeting BCMA in relapsed refractory myeloma patients. And in this study, the patients were heavily pretreated. They all received cyclophosphamide and fludarabine first prior to the CAR T cell infusion. This is called lymphodepleting conditioning, and it's been demonstrated to help enhance the expansion and perhaps persistence of these cells once you infuse them. And they looked at 4 different dose levels, and what they found, particularly at the higher dose levels, were objective responses, even in these highly refractory patients, some of which lasted 4 to 6 months. And the patients who had the greatest degree of expansion of the CAR cells were the ones who had the best responses. And it was associated with some of the same toxicities that had been described in the CART-19 experience, namely cytokine release syndrome and neurotoxicity. And this study is ongoing, and we'll hopefully have an updated ASH on more numbers of patients. Now at Penn, in conjunction with our collaborating scientists from Novartis, we've developed a different BCMA-specific CAR. This is a fully human CAR that was derived from screening human B-cell antibody libraries. It's packaged with our typical 401BB co-stimulatory domain and a lentiviral vector. And after extensive preclinical testing, we selected one lead candidate to go into first-in-human clinical trials. And our study is designed to look at 3 different cohorts. The first cohort, which I'll describe in detail, is just receiving CAR T cells alone without any lymphodepleting chemo. And then there are 2 subsequent cohorts which are getting cyclophosphamide first, followed in cohort 2 by a lower dose of CAR T cells, 10 to the 7th cells, and then a higher dose, 10 to the 8th cells. So we'll be able to get some sense of the differences in safety and efficacy looking in these different conditions. And so these are the characteristics of the first cohort who are just getting CAR T cells alone. We now have mature follow-up on this cohort. These were heavily pretreated patients with a median of 9 prior lines of therapy. They were refractory to most of our typical myeloma agents. They all had at least one high-risk cytogenetic feature, and 2/3 had a 17p deletion or TP53 mutation. This was a high tumor burden population with median of 80% plasma cells and had significant lymphocytopenia at baseline with a low median CD3 count. Despite this, we were able to generate successfully CAR T cells from all patients, though one patient did require a second apheresis and manufacturing attempt. So we were able to see objective responses of PR or better in 4 out of these 9 patients. 2 additional patients had minimal responses. This was associated with the greatest expansion of those patients who had the greatest response and with declines in soluble BCMA levels. And the patient who actually has had the most durable response has been patient 1, who actually now, this is data from last year's ASH, but is close to 2 years in a continued stringent complete remission after an infusion of the CAR cells without any subsequent intervening therapy. And so this shows the potential for this to create a durable remission in a patient without any other therapy, and this patient still has circulating CAR cells detectable. In the other subjects, however, most of the responses were not as durable. They lasted a median of 3 to 5 months before the patient subsequently relapsed. In addition, we could see responses in extramedullary disease. On the bottom right is a patient who had a malignant pleural effusion and paraspinal and pleural deposits, which all resolved by 30 days or so after the CAR infusions. And so this really confirms the NCI experience, showing proof of principle that you can target BCMA with these cells and get objective responses that can be durable in perhaps a subset of patients. At ASH this year, I'll be reporting the preliminary data with our Cytoxan-based cohorts, where we're showing a bit more persistence and increased frequency of responses. Now, we, of course, are not the only ones doing this. There are now several trials that have started for BCMA-directed CAR therapy, and I'll show you 2 more that have actually reported data. This is the study by Bluebird, which has a different CART-BCMA, a multi-center study, again, in relapsed refractory myeloma patients. They gave all patients Cytoxan and fludarabine conditioning first, and very impressive response rates in this study. You can see once they got to the higher dose levels of 150 million cells or higher, they've actually seen responses in every patient. And many of these responses with these black arrows are still durable and ongoing, some even now approaching a year. The final study that I'll discuss is this study from a Chinese company called Legend Biotech that was presented at ASCO this year. Not as much details were provided about the makeup of the CAR cell, although it is somewhat structurally different with 2 binding sites for BCMA. They used cyclophosphamide alone as conditioning, and this was really a different population than the other trials I've presented. These subjects had median of 3 or 4 prior lines, median not had a stem cell transplant, so an earlier line of therapy. Nonetheless, again, in the 19 patients who were evaluable, 19 of them are 100% responded, including a very high rate of stringent complete remission. And so really, we have 4 different studies now in sort of different centers, somewhat different populations, showing the power of this approach. There are, of course, several differences, and it's important to keep this in mind. This is still early days. All of these studies have only presented data on fewer than 20 patients, though hopefully we'll have updates at ASH. The co-stimulatory domains can differ between the different studies. Our study did not require any pre-existing or pre-specified level of BCMA on the myeloma cells, where the other studies actually did, and they excluded patients who didn't meet a certain threshold for level of expression, and you can see a significant proportion of patients were excluded from some of these studies. The median prior lines of therapy was somewhat different, and the conditioning, of course, was different as well. And so I think it's a little too early to compare head-to-head between all of these, but they all are really demonstrating promising results so far, and we, of course, need longer follow-up to see how durable these remissions are going to be. Now, unfortunately, there's no free lunch with CAR T cells, and these extraordinary responses do come at the cost of several somewhat unique toxicities that can be serious. So tumor lysis syndrome is somewhat expected and generally manageable. The B-cell aplasia that's seen with CD19-directed CAR cells, fortunately, has not been as much of an issue with BCMA, since most B cells don't actually express BCMA, though hypogammaglobulinemia can still be an issue that you can mitigate with IVIG. The two big ones remain cytokine release syndrome and neurotoxicity. So cytokine release can be mild, ranging from mild fevers and flu-like symptoms, up to more severe issues with hemodynamic instability that can require ICU-level care. And fortunately, we've learned that tocilizumab, the IL-6 receptor monoclonal antibody, can very rapidly abrogate the cytokine release syndrome and restore hemodynamic stability in patients. And there are studies now looking at using tocilizumab even preemptively in CAR patients before they start to get sick to see if we can perhaps prevent this. The neurotoxicity is more variable. It's seen not as frequently as cytokine release. Again, can be anything from mild confusion and headache all the way up to severe encephalopathy with obtundation, and there have been fatal cerebral edema cases reported, of course, in the CD19 CAR T cell experience. So these, I think, are things we still obviously need to learn more about and try to mitigate before this is expanded and brought earlier to patients. The other issue, of course, with CAR T cells are logistical. This is only available right now at limited centers. There are delays for manufacturing that can take anywhere from 2 to 4 weeks, and it can be difficult to maintain disease control during that time. And of course, the cost of this is significant and perhaps prohibitive if we try to apply this to large populations of patients. And so I think we're really in the early days of CAR cells for myeloma, but certainly this appears very bright in terms of its future. Now, with regard to some of these logistics, it certainly would be nice if you could get the same type of effect of getting your patient's T cells to attack their myeloma cells without having to extract the cells and ex vivo activate them. And so this is really the concept behind bispecific antibodies, or BiTEs. And so essentially what you have is a new molecule in which one part is specific for the CD3 portion of a T cell, which can activate that cell. The other part of SCFE is specific for a tumor-associated antigen on the cell surface, and you're able to bring the T cells to the tumor cells within the tumor microenvironment, activate those T cells, and cause T cell killing. And there have been a number of different targets which have been explored with this concept. The one that actually is furthest along is, again, CD19, and the BiTE is called blinatumomab, which, as you're aware, is FDA approved for relapse refractory ALL and has activity in B-cell non-Hodgkin's lymphomas as well. Now, it turns out that BiTEs are not the only format for bispecific antibodies. So the BiTEs are these very small molecules that have a very short half-life. They're relatively unstable in serum, and so you need to have it continuously infused, usually by a pump over several weeks, and it's very inconvenient for patients. And so there's a next generation of bispecifics that have more of a typical monoclonal antibody-like structure with an FC portion that provides greater stability and more favorable pharmacokinetics so that you could actually infuse them once a week or even every 2 weeks. And so a number of these next generation or IgG-like bispecifics are now going forward as well. And so there are no clinical data yet available for the bispecific antibodies, and I'm not going to go through all of the preclinical data, but I will say, at least in this one particular paper, where they directly compared head-to-head a CAR T cell specific for BCMA and then a bispecific antibody with the same specificity for BCMA, and they saw very similar activity in this preclinical xenograft model. And so there are at least 4 different bispecifics going forward against BCMA and myeloma, and the AMG 420 is the one that's furthest along, has been enrolling in Europe for some time, and will hopefully have some data soon. There's another target called FcRH5 that again is expressed primarily on plasma cells in a subset of B cells, where there's also very nice preclinical data supporting a bispecific in this setting. And so these studies are all opening right around now, and I'm hoping next year at this time we'll actually have some preliminary clinical data to get a sense of, does this work, how well does it work compared to CAR T cells, and what is the toxicity profile. We know that blinatumomab, for instance, can have neurotoxicity and a low incidence of cytokine release as well. And so we'll have to see how this compares to the CARs. Now, moving on from bispecifics and CARs to more traditional antibodies, what are the other antibody approaches going forward in myeloma? We've heard about CD38 and SLAM-F7 targeted antibodies. And so there's been a lot of interest in the blockade of the PD-1, PD-L1 pathway in myeloma. We heard some of the preclinical rationale from David earlier. And we also heard there was limited single-agent activity with PD-1 blockade in relapse refractory myeloma. There is, however, a lot of synergy with immunomodulatory drugs preclinically, and that led to 2 studies that were done, and I'm showing the one by Badras and colleagues from Maryland, combining pembrolizumab, a PD-1 blocker, with an IMiD. And so in this study, which was in relapse refractory myeloma patients who were naive to pomalidomide, they gave pembrolizumab, pom, and dex in a phase 2 study. And in 48 patients, the response rates were fairly impressive, 65%. Remember, the response rate to pom dex alone was roughly 30% in the phase 3 studies. And they did see some autoimmune toxicities, including pneumonitis, that were reversible with cessation of the drug and steroid treatment. And the median PFS was impressive. And so based on this study, as well as a second study using lenalidomide with pembro, there was a literal explosion of trials using PD-1 inhibitors in multiple myeloma. And this is a list with multiple different PD-1 or PD-L1 inhibitors and multiple different trials. And we had a couple of these open at Penn as well. And unfortunately, over the summer, there was data that emerged from the pembrolizumab combination studies that there were excess deaths in the arm getting pembrolizumab with the IMiD compared to the IMiD and dex alone. And this was seen both with pomalidomide and dex in relapse refractory myeloma and with lenalidomide and dex in newly diagnosed myeloma. And in addition to these excess deaths, there did not appear to be, at least in the preliminary assessment, which was about 250 to 300 patients in each trial, that there was any difference in response rates so far or in median time to progression. And so based on this adverse safety signal, the FDA actually shut down these trials and has actually now put a hold on all of the PD-1 trials in multiple myeloma. So none of these are going forward right now while we're waiting to get additional data from the other studies. And so it's not quite clear why this safety signal emerged here and wasn't shown in the phase 2 studies. And I think we really need to get additional information as to how these patients were being managed. Many of these were autoimmune type toxicities, including cardiac toxicities like myocarditis. But for now, at least, the PD-1 IMiD combinations are not going forward. And I think it remains to be seen what the role of PD-1, PD-L1 in myeloma is going to be. And I think I'll finish up with another novel antibody-based therapy in myeloma. This is an BCMA targeted drug that is not just a naked antibody, but an antibody drug conjugate. And so this takes a BCMA-specific antibody and attaches it to an auristatin derivative called MMAF. It's a microtubule inhibitor. And so this allows for 3 potential mechanisms of action to kill myeloma cells. You have at the top the typical antibody drug conjugate where you have binding to the receptor, in this case BCMA, internalization, cleavage of the linker that allows release of the MMAF toxin, and that induces apoptosis directly. The FC portion of this antibody has been afucosylated to enhance binding to effector cells like natural killer cells or monocytes, so you actually get enhanced ADCC, or antibody-dependent cellular cytotoxicity. And finally, this blocks BCMA signaling. It blocks the binding of APRIL and BAFF to these BCMA, so you block that survival signal to the myeloma cells. And so this demonstrated significant preclinical activity and led to a first-in-human phase 1 study in relapse refractory myeloma patients. This was a typical dose escalation design, starting from very low doses up to 4.6 mg per kilogram. The drug has a favorable infusion schedule. It's given over an hour, once every 3 weeks, and we would treat up for 16 cycles. MMAF, the auristatin derivative, has known corneal toxicity. It can get into the corneal epithelium, and so to mitigate that, patients were pre-treated with steroid eye drops for 4 days before and after each treatment. And this is the characteristics of the patients. We treated 30 patients in the dose escalation. 90% were dual refractory to a proteasome inhibitor and IMiD. Only a subset had seen daratumumab at the time within this dose escalation cohort. And importantly, we didn't see any dose-limiting toxicities escalating all the way up to 4.6 mg per kilogram. But the toxicities were as expected. Ocular toxicity were seen in over half the patients, and this could manifest as dry eye, blurry vision, photophobia, and corneal microcystic changes were seen on exam by the ophthalmologist. Fortunately, this was grade 1 or 2 in the majority of cases and did improve with holding of the drug and lowering of the doses, although some patients did have residual irritation of their eyes. The other toxicities were thrombocytopenia, fatigue, and anemia. Infusion reactions were seen in only a quarter of patients, exclusively with the first infusion and then not thereafter. And we didn't premedicate these patients with the first infusion. And there was a low rate of asymptomatic transaminase increases. And I think what's exciting with this drug as a single agent without any steroid or anything else is that as we got up towards higher doses, we actually started seeing objective responses in this heavily pretreated population, particularly if you look at the bottom where we dosed at 3.4 mg per kg or higher. Again, only 9 patients, but 6 out of those 9 patients responded, and at the time of this presentation, all of those responses were still ongoing, and some of these have been durable now for well over a year, year and a half. And so we've now accrued another 35 patients to the expansion cohort, and we'll be presenting updated data at ASH this year, but these response rates look like they're going to hold up. And so this really has very high single-agent activity in myeloma, and I think we obviously need to treat more patients, but it's another exciting way of targeting BCMA and a potential another approach here. And so I think to conclude, immunotherapy is coming for myeloma. This is my shout out to Game of Thrones fans out there. The role of PD-1, PD-L1 blockade, I think, is unclear. And it's interesting that these toxicities were seen in combination with IMiDs. They've obviously not been described in all of the solid tumor trials, or at least to this degree. And whether there'll be a role for PD-L1 or PD-1 blockade with other combinations like vaccines, as we heard with David, or with monoclonals, I think remains to be seen. I think there is more to explore here. I wouldn't conclude that this is not going to go forward at all. I think BCMA is clearly emerging right now as the most promising target for all of these new immunotherapies. We have documented responses with the CAR T cells and the antibody drug conjugate. The bispecifics are just now entering trials, and we'll see how those work as well. And really, a lot of questions and challenges. These are very early on. What are the optimal patient populations for this? Should we be screening for BCMA, level of expression or not? The toxicities obviously remain significant, particularly with CAR T cells. How are we going to sequence and combine these with our current therapies, which are showing such high response rates early on? But I think this will be nice challenges to have as we have, again, more tools in our toolbox to treat this disease. I'd just like to acknowledge all of my colleagues at Penn participating in the CAR T cell trial. It truly takes a village to run these studies, especially Carl June, sort of the father of our T cell program, as well as my collaborators at Glaxo on the antibody drug conjugate. And that's it. Thank you.